2011, I was feeling sick and I started vomiting, and I thought I would quit, but I vomited off and on all night long. We saw Dr. Knockleby. Dr. Knockleby asked me questions to my illness, and he told me I was a very sick girl and I needed to go to the hospital right away. In the emergency room, I saw Dr. Sabishi and Dr. Smith. Dr. Smith informed me that I was very, very ill.
Our hospital has adopted the Institute of Medicine's quality aims, so making sure that our care is safe, timely, effective, efficient, equitable, and patient-centered. And so as part of that, on an annual basis, we select a hospital-wide process improvement activity, and we base that on input from our physicians, from staff. And so in 2009, our hospitals had brought forth about the not having a sepsis protocol and a concern about that.
We used the Plan, Do, Study, Act methodology. We already had the data so that we knew our mortality rate was 50%, something that we could improve upon. We gathered a team that was specific for people who could bring changes to this PI project that we were starting. We used pharmacy. We needed their help with medications and order sets. We used information systems. We needed a computer person to develop the screen in our electronic medical record and make changes as necessary, because it is a fluid process. We always found that there are little things we needed to change, and as new improvements came along, we needed them to make those changes in our EMR screen as well. We involved education because there was a huge education piece for nursing and physicians as well. We also had the nursing unit leaders, because this was going to be rolled out to their areas. They needed to be familiar with it, see how it would work in their workflow.
And so we also knew to be successful we had to have a physician champion, a senior leadership champion, and then a leader of the team who's very invested in the process.
My part was mainly in regards of developing the sepsis protocol. Dr. Smith was working on a sepsis protocol for the emergency room. I was working on a sepsis protocol for the ICU. We also had a cooperation with the Bryan LGH in Lincoln, and because they had a similar project that they did several years back.
Our aim statement was to decrease our mortality by 25% within a year of implementation. And so we have data from August of 2010, when we implemented, through July of 2011, our mortality rate is 15.1. So we're very, very excited about the success of the project. We also looked at length of stay, and we looked at charges. That wasn't our original focus, but we thought it's important to tie dollars to quality. We basically dropped our average length of stay for, we divide them into groups, so like you have your septicemia group, your severe sepsis, and your septic shock. And so for septicemia people diagnosed with septicemia and for septic shock, we dropped the length of stay by almost half, and the same thing with the charges. And so that was another positive outcome as a result of our project.
My family and I are very grateful to the doctors, nurses, and staff, the care that we received up here while I was in my 14 days at Great Plains Regional Medical Center.
Nebraska's hospitals, your leaders in quality.